Yeah. Hello, ladies and gentlemen. Welcome to the APSC JCS 2020 webinar number 13 entitled APSC Update on COVID-19 in Asia. I'm Takashi Akasaka from Wakayama, Japan. I'm the Congress Chair of APSC 2020, and my co-chairman is the Professor Wei Chi Jaktam from Singapore. He is the president of an APSC. Today, we will have five speaker, and after introduction of my co-chairman Jaktan, uh, uh, we will have the presentation from the five speakers. And I hope all the audience enjoyed this session very much. So I would like to introduce my co-chairman, Dr. Jack Tan, Singapore, the president of an APSC. He will talk about the introduction of this session, please.
Thank you, Prof. You can hear me?
Yes, right? Well, very well.
So thanks a lot. First, I'd like to start off by congratulating JCS under the leadership of Professor Kimura as well as Professor Akasaka for doing this endeavor and switching APSC 2020 Kyoto to APSC JCS 2020 webinar format. I think this is unavoidable, and I want to congratulate the team at JCS for such hard work and for driving a successful meeting. Today's last session on the last day for APSC JCS, we're going to talk about the APSC update on COVID-19 in Asia, as well as experience sharing across the world. I think I just want to quickly set the stage for this session on this slide. I think the health footprint of this pandemic across time, we are 6 months into COVID-19. We have gone past for most countries the immediate mortality, morbidity impact of COVID-19. A little bit of difference between maybe the West and countries which has some scar tissues from SARS first one, for example, Singapore, Hong Kong, Korea, China. We were probably more prepared for what a pandemic or pandemic-like version 1 looks like. So we took less of probably a mortality, morbidity impact from COVID-19 as a first wave. But 6 months in, we're moving on to the second and third wave where there's true interruption of chronic disease care like CVD, NCD, COPD, and probably cancer care as well. And we have, as a professional body, guard against the interruption of this chronic care impact that will really increase mortality in the year or two to come. We also should not neglect the fourth phase for this pandemic, which is moving rapidly into long-term mental stress, burnout, economic, as well as psychiatric trauma that both patients, economy, as well as front-facing staff, not just doctors, I would say, all front-facing staff is experiencing. But my last slide, I want to talk about some challenges and opportunities lying ahead. I think we have to guard against collateral damage. We have to guard against some of the inequalities for cardiovascular care as well as access across Asia Pacific. And we have to guard against this neglect of attention for the growing problem of NCD, which know that is a big problem in Asia, as well as reduced funding for research. I think there are a lot of researchers on this panel, and we know that even during this pandemic, research is halted. We hope that research for cardiovascular research funding is not impacted. I think we also have to guard against not just this black swan event of a pandemic, but other known unknowns. As a professional body, there are other known unknowns we have to guard against, whether it's climate change, tobacco cessation, or NCD care. We know it's coming. We have to work harder at it and not just be blinded by COVID-19. So I think some opportunities moving forward, we as a region can consider evolving further models or leapfrogging new models of care to something that what patients need and maybe transcend the patient can see you now type of care with new technologies. I think we do show in this kind of seminar there's a desire to collaborate and progress together. And we are very happy that we have multiple rounds of collaboration with both ESC, ACC, WHF, in many endeavors. And the first endeavor that we're embarking upon is a coming ESC APSC pilot exit exam in November 24th, followed by ESC Asia event in December 2020. So with that, I'd like to get Prof to welcome our first speaker. Thank you very much.
Okay, thank you, Jack. The wonderful introduction. So I would like to introduce my Korean friend. He was the president of Korean Society of Cardiology, Professor Kee-Sik Kim. His talk is entitled "What We Did Well: Observation in Korea." Professor Kim, please.
Okay, good afternoon, ladies and gentlemen. It's my great pleasure to have this kind of lecture to all the experienced the experience that actually in Korea, as you know that after Wuhan crisis, after then the Daegu crisis in Korea. Daegu is I'm living in Daegu city, so I have a lot of patients. COVID-19 patient. So I would like to share. I'd like to share with you my experience. In here, the first Korean patient diagnosed on January 20th. After then, nearly 1 month, very few patients was developed. So but however, the February 18th, the index case was diagnosed. After then, like this way, COVID-19 is increased very rapidly, especially in my Daegu city. So in this time, we have a lot of experience and have a lot of chaotic situations in this city. At that time, this is big, widest road in Daegu, downtown. There are no car. In here, Dongdaegu station, there is no passengers. And in here, long lane to buy a facial mask at that time. So currently in Korea, it is several days ago, statistics, in Korea, confirmed cases of 14,000, more than 14,000, released from isolation 13,000, and the disease patient is 300. The mortality rate is 2.1% in South Korea. The test was, a lot of tests was performed, but the positive test rate is 0.9%. Here, my city is here. Still, we in Daegu city, last 1 month, no patient was occurred. So, however, it is nearly 7,000 patients diagnosed at the first phase of the first phase of the this infectious era. What did we did during the outbreak of COVID-19 patients? At first, control the hospital entrance and exit and reduce the number of inpatients, prepare MICU and the general ward for COVID-19 patients. And the telemedicine is illegal at that time, illegal in South Korea. But however, at that time, we started telemedicine for prescription who could not or who do not want to come to visit the hospital, and prepare one test lab for acute coronary syndrome, and drive through and working through test. This is first in South Korea, and the other one I would like to focus on the community treatment center for asymptomatic or mildly symptomatic patients. This is drive through in Daegu area. There are several general hospitals. Every hospital keep like this drive-through test. Here in the car, you can be taken the RT-PCR. Here is the slide. Here in February, from February and March is the peak area. In this time, a lot of telemedicine was telemedicine was performed, and the visited outpatient clinic, a lot of patients uh, decreased rapidly, and the primary PCR cases also decreased. So how to control the asymptomatic or mild symptom positive patient? We developed the community treatment center. Dr. Wu is from Wuhan and suggested that 8% of COVID-19 patients would have a very mild upper respiratory infection without hypoxia, and only 20% of infected patients need to medical service. Considering asymptomatic carrier transmission, high reproductive ratio, and the possibility of sudden deterioration, even patients with mild or no symptoms should be isolated and monitored. So the CTC is designed to monitor and isolate patients with mild conditions during emerging infectious disease outbreak. At that time, the March 1st in Daegu situation, the cumulative number of patients is 12, more than 12, 12,500. But at that time, admission at hospital nearly 900. It's overloaded. It's already overloaded. Waiting for admission is 1,500. So at that time, deaths, 3 deaths, two were two were two were deaths at home. So at that time, two cities in Daegu metropolitan proposed by the local government. This was operated March 2nd to April 3rd, April 13th. 533 rooms available. One is educational training building, and the second one is a student dormitory in college. Doctor, nurse, medical technician is a volunteer. And we keep portable X-ray and auto saturation machine and the EMR, which can connect the expert of this disease. The patient was assessed by doctors, nurses through the telephone 2 times every day, and check body temperature and respiratory symptom routinely, assessed by self-monitoring and reporting. So recently, this the natural cause of COVID-19 in non-symptomatic, asymptomatic, mild symptomatic, and asymptomatic patients was published in the emerging infectious disease. This one is one building inside is an educational training building here. So we keep this building for very mild patients here. At that time, many ambulance stayed around here to transport, and a lot of military doctor came to here for taking the patient. So this is a flow sheet of the who can admit to this CTC. The RT-PCR, the COVID-19 positive patient, symptom negative or minor symptom. At that first time, the home self isolation or community treatment CTC, and symptom positive symptom is moderate to severe, and the hospital to coronary disease or tertiary hospital they transport. In the CTC, clinical course is like this, right? After admission, 7 days later, RT-PCR rechecked. In here, the negative RT-PCR, the result was negative. 24 hours later, reassessed RT-PCR again. If the negative, discharge, or if the patient shows the positive findings, 7 days later, recheck. Or to inconclusive result, 40 hours later, rechecked it again. So this was a repeated course. So if the patient have some respiratory symptoms, such as dyspnea or chest pain, take a chest X-ray and portable oximeter. Is abnormal, it transferred to the hospital. This was the result. Total 232 patients was admitted in this CTC. 68% were female and 32 patients was male. The mean age was 40, and 112 patients had at least one underlying condition, and another COVID diagnosis self-isolated. Self-isolated at the home period is average nearly 1 week. In here, 75 patients showed a mild symptom, 186 patients at first the symptom negative to convert to the symptom mild symptom positive. 371 patients, nearly 59% symptom negative until the day discharge. Among them, the 19 patients, 30% transferred to hospital. Among them, only 14 patients have a respiratory symptom, and five had other causes such as anxiety or pregnancy. Here, after excluding the patient transferred to the hospital, the 19.4% patient had virologic remission and they were discharged from CTC. The virologic remission period was average 20 days. And I will show the, okay. What I will show the later in the bar graph. Here is the clinical characteristics of patients admitted to the CTC. Total 632, male is 32%. Here, over 50 is nearly 37%. Here is a comparison of hospitalization and the non-hospitalization patient. Here, the hospitalization patient has a little bit higher age and at least one any comorbidity. Cumulative rate of negative conversion of virus test after diagnosis here, 1 week just 0.3%, average 3 week average 57%. Some patients until more than 6 weeks. 6 weeks, 91% negative conversion. Here is a symptom at admission. This gray bar shows the symptom at first the symptom negative to convert it to the symptom positive. This group is showed us very slow viral remission. This is asymptomatic patient and the comparison of asymptomatic and the symptomatic patient converted to the negative serologic, negative RT-PCR test. Here, this is a red line is the asymptomatic patient. Is much faster than the symptomatic patient to negative virologic test. The symptom onset and the remission of mildly symptomatic patient. Here, the 10 days from diagnosis and to symptom positive, it took 10 days. From symptom and virologic negative status, 11 days. It took 11 days. So nearly 21 days or 22 days is needed. This is shows the aging. According to the aging, the over 60 is a more higher instance of the transfer to hospital. Their symptom is more serious. This is patient's comorbidity. According to the patient's morbidity, the comorbidity negative and this blue line is a positive. The blue line shows the higher, the community positive patient shows higher hospitalization rate. So this is near my, so this is, we need a peak, reduce the peak. So reduce the spread and minimize the health risk of patient and maintain the healthcare system. So we can maybe Daegu city at first like this way, but nowadays like this way. So this is my conclusion. The community treatment center could isolate asymptomatic and mildly asymptomatic patients very effectively, which might be reducing hospital overload and preventing spread of infection. These results demonstrate the natural cause of COVID-19 in a large population of asymptomatic and mildly symptomatic patients. This data might be helpful to planning isolation center and formulating self-isolation guideline for public. This is a current situation. This is a daycare room for very young children. This is my grandson. They all took a mask during the staying this daycare room. Thank you very much.
Okay, thank you very much for a wonderful presentation. In Korea, you succeed to control the COVID first wave very well, right? Because of community treatment center and also the drive-through testing, right?
Yes, that's right.
Is it possible to lock down by law from the government?
At first, the government tried to lock down the Daegu city, but many people against that. So maybe the Daegu citizen self-lockdown status at first time.
We learn a lot from the Korean style, and we are now trying to follow your style. But the problem in Japan now is we have, I'm not sure that the second wave may, yes, occur, and we are very worried about the condition. How about the Korea? Because the economical condition and also the medical condition, it's yeah, big different control condition, I think. So after yes, opening to the economical condition, we have the yes risk of a second wave. How about the Korea, right?
Yeah, Korea is nearly the same situation. We are worried about the second wave, maybe September to October. Someone suggests that the second wave will come to at that time. But however, nowadays the daily patient of 10 to 50. So we can control this COVID-19 very well. Most of them are from foreign country.
Okay, thank you very much. So we'll discuss later. Thank you very much. So I would like to introduce the second speaker, Dr. Xiang Cheng from Wuhan, China. He cannot join at the moment, therefore, but we could have his video or presentation. So we would like to start his presentation.
Hello, ladies and gentlemen. I'm Xiang Cheng, Director of Department of Cardiology in Union Hospital. I'm from Wuhan, the epicenter of COVID-19 in China. Today, I would like to introduce the changes in the work mode of cardiologists during COVID-19 epidemic in Wuhan. Wuhan is an international big city in central China with a population of more than 12 million. It is a transportation hub in central China. Due to the COVID-19 outbreak, the government took the extraordinary step of locking down Wuhan on January 23, 2020. We can see that the left picture is the prosperous light view of Wuhan before locking down, and the right picture is after locking down. There are no vehicles on the spacious street. Wuhan is the most seriously infected city in China. There are up to 50,000 confirmed cases. Severe critical case ratio is about 20%, and the mortality is about 7.5%. Although COVID-19 mainly affects the respiratory system, as a cardiologist in the center of the epidemic, we also face great challenges. Firstly, medical staff is insufficiency. During the epidemic, the hospitals in Wuhan have been divided into COVID-19 designated hospitals for the treatment of confirmed COVID-19 patients and long-designated hospitals for the treatment of long COVID-19 patients in critical condition, such as blood cancers, acute cardiovascular and cerebrovascular diseases. Our hospital is a long-designated COVID-19 hospital. Many cardiologists from my department go to assist other medical units, such as fever clinics, emergency rooms, isolation wards, designated hospitals, and Fangchang shelter hospitals. Unfortunately, some medical staff were infected in the early stage, which aggravated the shortage of the medical staff. Secondly, medical resources are insufficient. We didn't have enough medical instrument and protective equipment in the early stage, such as ventilator, ECMO, a 95 mask, and a protection suit. Thirdly, we were facing difficulty in treating cardiovascular emergencies. Cardiovascular emergencies need urgent treatment to save life. However, almost all the local residents in Wuhan may have a history of COVID-19 contact. They were not able to be quickly ruled out and to receive timely treatment. Meanwhile, there's no negative pressure catheter room in Wuhan, so it is difficult to carry out emergency cardiac intervention. And the last challenge is for the patient with chronic cardiovascular diseases such as hypertension, stable coronary heart disease, and chronic heart failure. They need long-term medication and regular follow-up. But the traffic is inconvenient after the locking down of the city. The patients were afraid of COVID-19 infection and unwilling to go to the hospital. All this leads to the difficulty in the management of chronic cardiovascular diseases. During the difficult time, the government provided excellent aid to Wuhan. Medical teams from all over the country have successfully supported Wuhan. In addition, with strong support of the government, designated hospitals and Fangchang shelter hospitals were quickly established. Wuhan also received medical resources from all over the world. Facing so many challenges, the work mode of cardiologists was changed. During the particular period, the Chinese Society of Cardiology organized 125 nationwide experts to write the consensus, CSC expert consensus, on the principle of clinical management of patients with severe emergent cardiovascular diseases during the academic period of COVID-19, which identified 4 core principles during the epidemic. Academic control as the first priority, proper risk assessment, preference for conservative medical therapy, and strict measurement to limit infection spread within the hospital and to health care workers. Firstly, according to the consensus, for patients with cardiovascular emergencies, such as STEMI, we changed interventional therapy to conservative treatment. A thrombolytic team was set up in our department to treat STEMI patients in the emergency room. This case is a STEMI patient who was successfully treated by thrombolysis in emergency room. After thrombolysis, the symptoms disappeared and ST segment decreased significantly, indicating successful thrombolysis. After process optimization, the time from the first ECG to thrombolysis was shortened to an average of 47 minutes. To treat chronic cardiovascular diseases, hospitals used internet-based medical treatment. Online consultations were carried out to provide regular diagnosis and treatment services to patients. Then, online prescription systems were generated so patients could obtain medical without going to the hospital. Finally, mail services were established to provide patients with drug services which reduced difficult travel and possible cross-infection. We also trained primary doctors through online meetings. Our department has established a WeChat group for follow-up patients after PCI. During the epidemic, we follow them up and solve some problems in WeChat group online. Thirdly, cardiologists changed to infectious disease doctors. Rigorous nosocomial infection control training must be completed before starting work. Cardiologists learning how to wear and take off protective suits and disinfect different areas. Thus, cardiologists strengthen their understanding, protection, and management of infectious diseases. Because some of the symptoms of COVID-19 are similar to cardiovascular diseases, some patients go to the cardiovascular department by mistake. So, we should use proper protection in the outpatient department. As you can see, patients in the waiting area should be as dispersed as possible, more than 1.5 meters apart. Patients would take a temperature measurement first. During the consultation, the number calling system was used, and the strict implementation of one doctor, one patient, and one consultation room was performed to avoid cross-infection. For patients who require cardiology inpatient care, our hospital has established an admission system for patients. Patients who needed to be hospitalized should undergo COVID-19 screening immediately. If COVID-19 was diagnosed, Chieh would be transferred to the designated hospital. If COVID-19 cannot be ruled out, Chieh would be transferred to an isolation ward in infectious department for treatment. If COVID-19 was excluded temporarily, Chieh would be transferred to the emergency buffer ward for treatment. After admission, these patients would be re-examined for COVID-19 to comprehensively assess whether there was a risk for COVID-19. If COVID-19 was still excluded, Chieh would be transferred to CCU in cardiology department. The CCU ward adopted the strict principle of single-room admission, and inpatients can only be accompanied by at most one family member. The accompanying family member must complete the COVID-19 investigation, including CT lung screening, nucleic acid, and specific IgM and IgG antibody tests. After 5 to 7 days of observation in the CCU, a comprehensive assessment of COVID-19 was performed. If COVID-19 was excluded, Chieh could be transferred to regular medicine floor ward with shared rooms. The admission process of buffer ward first, regular medicine ward thereafter mode effectively prevent cross-infection in a hospital and also allows patients to be treated in time. In the cardiology ward, 3 districts and 2 channels were renovated. The cardiology ward implements unidirectional long-circulating channel to distinguish staff channels from patient channels. In addition, we also have dedicated buffer area for wearing and taking of protection suits. We strictly implement the nosocomial infection protection requirement to prevent cross-infection. At last, the COVID-19 epidemic promotes multidisciplinary cooperation mode. In designated hospitals, due to the lack of infectious doctors, multidisciplinary doctors, including cardiologists, work together to manage COVID-19 patients. In non-designated hospitals, because COVID-19 may lead to multiple organ dysfunction, cardiologists were also invited to join the MDT team for COVID-19 online consultation. During the epidemic of COVID-19, cardiologists in Wuhan face many difficulties, such as medical staff insufficiency, medical resource insufficiency, management difficulties in patients with cardiovascular emergencies and chronic cardiovascular diseases. With the support of the government, cardiologists in Wuhan quickly changed their work mode and gradually explored the treatment method for cardiovascular emergencies and chronic cardiovascular diseases in the current anti-epidemic situation. I would like to thank the government and the people of the whole country for their support for Wuhan. Thank you for your attention.
Okay, thank you. Dr. Cheng is not enter the live webinar. Therefore, I think the lots of audience may have a lot of questions to him. But finally, if we will have the chance to communicate with him, we try to have some discussion. Then let's move on the European experience. Today we have two friends from Europe. The first speaker is the Professor Barbara Casedei from United Kingdom. She is now the president of European Society of Cardiologists, and her talk today entitled "Lesson Learned in United Kingdom." Please.
Thank you. Thank you very much. I will put my slides up in a moment, but in the meanwhile, thank you for inviting me to take part here. We have learned a lot of lessons from COVID-19 in the UK, but unfortunately, most of them too late. So let me see whether I can share my screen effectively. Okay, so do you see the slides well? Yeah?
Yes, yes.
Thank you very much. So as I said, let's start immediately from a public health perspective and find out really what it is that was bad about the UK reaction to the COVID-19 pandemic and what it is that was good. So bad was that for some reason, even though Italy was hit before the UK, we failed to see it coming. Preparation before we had the epidemic was very poor. And so we had late lockdown, we experienced very scarce PPE availability, delayed testing, no tracking in place, and a certain amount of chaos and mixed messages, which really didn't help, and they are still ongoing, unfortunately. What it is that was particularly good is that the UK has a digitized national health system. And thanks to that, it was able to follow some trends nearly real time, and therefore be able to react to them quite quickly, and also use this infrastructure to run very successful, large, pragmatic, randomized clinical trials with an adaptive design, such as recovery. And there is also other cohort in the UK, such as UK Biobank, that were really very effective in allowing really to follow, allowing us to follow the epidemic and the inequality in risk to COVID-19. We also had not quite community centers, but dedicated hospitals for COVID-19 patients, the Nightingale Hospital, which unfortunately were never properly staffed. So although the idea was good, they weren't really followed, they weren't really used effectively. So as a result of all of these bad things, the UK has had one of the highest death rate among the countries. And you can see here, total excess deaths is only second to the US, which is a much larger country. And if you look per million of people, you also see that the UK is pretty high up here and higher than Italy. If you compare it to the average of the European Union here in pale blue, the UK did much worse in terms of deaths attributed to COVID-19. And you can see how much worse both the UK and the European Union did compared with South Korea or Japan. So the other problem in non-instigating an early lockdown, as the Italians have done, is that the cases and deaths of COVID spread all over the country. So as you can see here, with some clustering around the major cities, but it was not at all contained. And this is really one of the underlying reasons for the very high death, in addition to an absolutely fatal mistake, I mean, literally fatal, that was to discharge people from the hospital with COVID into care home, where they infected the rest of the other elderly people with disastrous consequences. So, as I said, we have a digitized health system, and this has really nailed the distribution of COVID and the risk factors of COVID, I think, for COVID very, very well. So first of all, let's look at, there is something missing here. Let's look at death by age. I mean, this is hospitalization by age, but I could say that death follow exactly the same pattern. In fact, even more dramatically so. And so you cannot see hardly any death below the age of 50, and this has been seen in other countries. And there is also a difference that is not clear here, but it's clear on the mortality data between male and female. So although the differences that we see in COVID-19 death with age are by far the largest of any other difference underpinned by other risk factors, there hasn't been any attempt to shield people or release people from shielding on the basis of age, which is really surprising. So everybody, though, is talking about other risk factor, and in particularly chronic cardiac disease as a risk factor for COVID death. And, you know, if you can see, if you take everything into consideration in a learning health system, such as the one in the UK, and you look here at the whole nation, 17 million patients and 10,000 COVID deaths in this study that is in press in Nature, then you can see that once you adjust for age, the chronic cardiac disease is not such a, prominent risk factor for death for COVID-19, and certainly is not as bad as age, as you can see here. I mean, note that we are on a logarithmic scale here, so the difference in mortality in age is phenomenal, yeah, and or indeed male sex, or indeed obesity, or deprivation. So you can see that these are much larger a risk factor for COVID death than cardiovascular disease or hematological malignancies, for instance. So that is important to know, but when you look at data like that, then you have to remember that they can reflect both the individual risk of infection, but also the risk of dying once infected. So you need to make sure that you do not see this difference in age or in sex, for instance, because male or elderly people are more likely to be infected. And for that, you can look at the serology study done within UK Biobank, 10,000 participants and their offsprings, children and grandchildren, followed up periodically over time, also to look at the time course of the antibody reaction. And you can see them shortly after the infection. You can see that there is no difference between women and men. In the UK, 7% were infected, both women and men the same. And you can see also that despite the fact that mortality is so much higher in the elderly, it is the young people that are infected, that are more likely to be infected, and probably because they go around more, they meet their friends, and they don't really take a lot of precautions, or not as many. So you could see that the difference is from about 11% to 5% in the over 70s. So as I said then, that the digitized National Health Service can really be key as an infrastructure to support large clinical trials. And the UK, and particularly Oxford, has done that very well with the recovery trial, an adaptive trial that was set up in about 9 days and enrolled very rapidly more than 11,000 patients from all the 175 National Health Service hospitals in the UK. And you all are aware that the really solid data on antiviral and hydroxychloroquine showing essentially no efficacy of this treatment in hospitalized COVID-19 patients came out from this trial, as well as the fact that dexamethasone in severe can decrease mortality in up to 1/3 of hospitalized patients. So a very important results, given also the availability and the cost of dexamethasone. The other way that we were able to use the National Health Service of the UK is to really follow really near real time the pattern of hospitalization, in this case for acute coronary syndrome, during the pandemic. And this is very important because when you do it real time for the whole nation, you can see how it develops, whether it depends on the intensity of the infection in a particular region or not, whether there are particular categories you need to pay attention, and also allows you to do an intervention and then see the results. So this study has recently been published in the Lancet, and what it essentially shows is that during the pandemic outbreak, there was a reduction in hospitalization for acute coronary syndrome. This has been shown by others, but the idea of this is the advantage of this is that it's for the whole country and it is over time. So this statistic will be updated continually. So it's a live paper in that respect. And so what do you see? So this is the beginning of the lockdown. And if you look at this is the previous year. So if you look at the average of any acute coronary syndrome from the previous year, you can see that the decline in admission started when the first COVID-19 death was reported in the UK, and the media started using what is called a language of fear. Stay home is dangerous and all of that. And people didn't come to hospital for an acute coronary syndrome or indeed a stroke. Which is incredible, but it did happen. And so you can also see that this is not due to the lockdown, right? Because people say, oh, during the lockdown, less pollution, less exercise, this and that's why less acute coronary syndrome, but that is not the case. You can also see here that the trend reverses at the beginning of April. And that is not due to the fact that the infection rate is getting better. If you look at deaths here, we are right at the peak when this reverses. And so it's due to a campaign of information that started from the European Society of Cardiology to all the national cardiac societies that then started talking to patients, going to television and say, a heart attack is a heart attack. You still need to call 999. Stay home does not apply to it. And it worked. It worked in the UK and in other countries that did monitor, such as Sweden, Poland, and others. So this was a positive result. So nevertheless, over this time here, only in England, there were about 5,000 people that did not manage to go to hospital with a heart attack. And if you multiply that for all the nations in Europe where this happened, plus other things, as I said, stroke, cancer, then you can see how big the collateral damage that Dr. Tan was referring to in his introduction will be. And we have some ideas already, because the COVID-related deaths, as shown here, do not account or account for only a portion of the total excess mortality that we are observing at this time. So here is the normal mortality that we would observe in England over this time, right? The dotted line. Here is the mortality, the excess deaths. This is the portion that is attributed to COVID, which is about 64%. But there is something else here, that is not attributable to COVID. And although, these data are never perfect, you could see this pattern again and again. And these are the data from Italy for the Lombardy region, one of the most affected region by COVID. And you can see that the death by COVID here in yellow is only accounting for about 50% of what is the total excess mortality that was recorded over that time. So in summary, what I could say is that the UK response to COVID has been slow and not very organized, and this has had a cost, and many lives were lost to some extent, I think, unnecessarily. So the good thing is that the UK digitized health system and other data sources such as UK Biobank have really highlighted disparities in the risk and outcome of COVID-19 very, very accurately. And have also provided an infrastructure for undertaking quick and pragmatic randomized clinical trials that have been benefiting, I think, the world with that knowledge. So the impact of the pandemic on non-COVID-19 mortality has been significant. And this is really something we need to keep an eye on. I have a slogan that is, we need to keep saving the lives that we know how to save. And I think that really needs to be kept in mind and in the forefront of our planning. So in England only, we saw a 40% reduction in hospital admission for acute coronary syndrome. And as I said, we have a campaign that partially reversed that. But nevertheless, as I said, we had more than 5,000 patients who did not receive treatment that we know is a life-saving treatment and prevents disability. And so we are expecting to see that, and also an epidemic of heart failure coming out of this non-treated myocardial infarction. We're back in the 70s, in other words. And so I think that this and others have contributed to the excess non-COVID related mortality that has been observed elsewhere. So I finished with that. Thank you very much.
Thank you very much, Professor Casedei. I understand the UK experience very well. And yes, you are not the continental connection to directly. The island countries are similar to the Japan or New Zealand or Australia. So the other country succeed to control the COVID very well. But UK.
Yes, I know.
But
I know.
Prof,
Yes.
can I just make a few comments?
Please.
I thought I really loved Barbara's presentation. It was factual. It was very honest, and I learned a lot from it. I just want to say something to the positive. I think it's not all bad, actually, Barbara. I think when I heard Professor Kim's lecture and China's experience, now UK, countries really leverage on the fact that you do have a very robust biomedical as well as institutional study culture. And I think you were leading the way in terms of, for example, vaccine development with AstraZeneca.
Yes.
And that is really the right population to test vaccines on, not in a population where I don't have the virus raging. So I think there is a silver lining to it. Just some questions though. I was surprised to see that there's no gender differences, because I saw a lot of data in my own country's data. There was a male prevalence for infection rates as well as mortality. So I was surprised to see there was no difference in your data as well. And the other thing is, I want to hasten a caution though, because I did see that over and beyond the age as a mortality, which is similar, I think, in most countries, including Singapore, for mortality rate increase. I was shown a series of post-mortem autopsy findings in those that died suddenly of COVID-19. And there was an increased findings of Kawasaki-like perivascular infiltrates, some myocarditis, and some scarring even in convalescing patients. So I think for our community, we also maybe have to watch out. If the rates were so high in UK, maybe 1 or 2 years down, you have presentation for cardiomyopathy, as well as heart failure in a subgroup that may be young, no longer old. So I think there's more to be done. We don't know. I think COVID does in some patients manifest as a systemic disease that I think UK can continue to lead some of the research efforts because your prevalence rate, like maybe Italy, was fairly high. So some comments.
So very briefly, to answer your question, there was definitely an excess in males. I'm sorry it didn't come out. Something happened to my mortality slide, but there was, being a male is a higher risk factor than having cardiovascular disease. So that's one. Two, I think that at the moment, the vaccines are actually being tested in Brazil, the Oxford vaccine, because the cases are even higher. And so that is the other thing. I have reviewed all the present report on autopsies from these patients. And I think it's difficult to know. And in most cases do not show an infiltrate in the heart. So a direct involvement in the heart. But there is a recent paper that with using MR that shows inflammation. We will see. We will see whether that will have long-term sequelae. There are 3 studies in the UK that are follow on these patients long time, so that the answer would certainly be available. Thank you.
Excellent. Thank you very much.
Okay, thank you very much. So because of time limitation, I would like to introduce our final speaker, Dr. Matthew Hu Min-mar from Taiwan. Yes, welcome. And his talk today entitled "What We Did Well: Observation in Taiwan." Taiwan is succeeded to control the COVID very well, so we have to learn a lot. Please.
Okay, thank you, Professor Akasaka. It's my honor and privilege to talk to you on the Taiwan experience. Let me share my slide. Are you able to see my presentation?
Yes, very well.
All right, hold on a second. Okay, so good afternoon. I'm Dr. Ma from National Taiwan University. I'm very honored and privileged to be here and this afternoon, and I hope to share with you how Taiwan reacted to the pandemic from a different perspective, from a community response perspective. And that resulted in one of the lowest number of infections in the world and rather preserved social and economic activities. First, I would like to introduce my hospital. National Taiwan University Hospital was established in 1895 and has become the leading medical institution in Taiwan. Currently, the health system has 7 branch hospitals. Yunnan branch, where I'm situated, is located in southern Taiwan and has become part of the health system since 2004. Taiwan is an island of 23 million people just off the coast of China, was predicted to have the second highest important risk of any country. With the proximity of China and almost 800,000 people living or working in China, and rather small number of COVID-19 in Taiwan, which up to yesterday was 647 cases, is rather extraordinary. During the epidemic, the school remained open. There's no major lockdown as the streets are bustling. Even the baseball game resumed early in May. So Taiwan was hailed as one of the best global responses to the COVID-19 pandemic. So how did Taiwan do it from a community point of view? We can summarize Taiwan's success so far in containing the pandemic into 3 elements. First is the preparation and early action, the centralized command system, and the wide use of big data and technology early during the epidemic. From the hard lesson learned during the SARS epidemic in 2003, Taiwan has overhauled the national pandemic response systems and always on high alert for the emerging epidemics. The capability of the Center of Disease Control was greatly improved since SARS, and the central monitoring system implemented drills for new emerging pandemics were conducted every single year. In the midnight of December 31st, 2019, the Deputy Director of Taiwan CDC, who browsed the Taiwan Reddit discussion group and ran across a posting about a cluster of atypical pneumonia caused by coronavirus in Wuhan. It contains some health department guidelines and clinical case information released by the whistleblower Dr. Lee from Wuhan. And this put the CDC staff in Taiwan on very high alert. In the same day, Taiwan CDC started border control and onboard quarantine services for flights coming out of Wuhan. This was probably the first among all nations in the world. So when you compare actions from different countries during the early stage of the pandemic, you will find that Taiwan did pretty much the same things with other neighboring nations or countries in Europe or North America, except that we did them very much faster. A series of early on, and this includes booking quarantine hotels before boarding, onboard quarantine, mobile phone-based quarantine services to entry, fever and symptom screening and entry, special quarantine taxes, services, and home quarantine arrangements. Comprehensive home quarantine and isolation arrangements of inbound travelers and close contacts were early implemented. They will be contacted by either civil officers or local health officers twice a day and checked by mobile phone-based electronic security monitoring system. From the SARS epidemic, we realized the strategic importance of the mask. The significant role masks played in containing the spread of coronavirus, especially when social distancing could not be adequately maintained, is verified later during this pandemic. The WHO later also advises to wear masks in public areas, especially when social distancing cannot be maintained. So As early as January 24th, mass export was banned in Taiwan, and national teams were assembled to gear up domestic mask productions, and we also started mask rationing nationwide. The daily production of surgical masks was increased from 1.8 million per day in January to 16 million 3 months later into the pandemic. This made Taiwan the second largest producer of surgical masks. The second most important element was a centralized command center. Taiwan officially activates the Central Epidemic Command Center, a branch within the National Health Command Center by January 20th, which allowed coordination with various ministries to enact policies and strategies already in place. Over 200 regulations and responses were promulgated by the Central Command very rapidly after the pandemic, based on our prior experience from SARS. This includes home isolation quarantine measures, supply of PPE, prohibition of disinformation, recruiting specialists, and promoting international collaborations, amending Communicable Disease Control Act, mobilizing resources, enhancing hospital infection control, standardizing communicable disease surveillance system, and optimizing border quarantine. Since January 20th, the Minister of Health presents facts, explains reasons behind measures, clarifies rumors, and answers questions every single day. In the later half of the epidemic, he enjoys an approval rate over 90%. The Central Command laid out instructions for social distancing measures, but we never implemented a major lockdown. Frequent, transparent communication and education from the Central Command won public trust. In responding to the calls of the mass screening, the commander became an epidemiology professor and explained why a large-scale community screening in low-prevalent community like Taiwan could lead to false positive results. In addition to the fact, science, and information delivered, the Central Command was successful also in conveying sense of empathy and humor. One day when they learned a boy was bullied at school for wearing a pink mask, all commanders in the Central Command Center wore pink at the conference to support the boys. A pandemic hotline was set up by CDC to respond to all inquiries related to coronavirus, and all pertinent information was translated into the commands from the mascot Shiba dog Inu, and humor was used to dissolve rumor. Because in the early week of the pandemic, there was a panic buy of tissue paper, like many places in the world, because there was a rumor that all tissue paper material was confiscated to make surgical masks. In this rather amusing ad, we can see the rear end of our prime minister. And the ad says, "We only have one pair of buttocks. Please stop the hoarding of tissue paper." And it did stop the hoarding of tissue paper in just a few days. The third important element leading to Taiwan's success in the use is the use of big data and technology. Many of the actions were made possible by the name-based mask rationing was made possible by apps and maps developed over the National Health Insurance Identity ID systems. Actually, over 130 various IT tools have been developed by private and public entities during the pandemic. Using the national insurance card, one can purchase masks from neighboring pharmacy and also in all the convenience stores. To protect our hospitals and healthcare systems, data from National Health Insurance Administration and Immigration Agency were linked to identify patients' 14 travel history. This later was expanded to identify particular occupations. This system were implemented very early on at all levels of hospitals and clinics to protect the healthcare system and healthcare providers. An electric fence system has developed over mobile phone signals from late January to mid-February. It checks individual locations every 10 minutes and reports any violations. The system has the capacity to monitor up to 100,000 individuals at the same time. And this became an IT skeleton of the comprehensive home quarantine tracking and enforcing system. The very famous Diamond Princess cruise also docked in Taiwan overnight. During the contact tracing of the Diamond Princess passengers, digital contact tracing system was developed that used big sensor data to explore passenger routes and to inform potential contact for public health tracing. During the naval supply ship Panshi cluster, digital contact tracing was again deployed to track the 700 or so sailors, and very fortunately, there was no community cases associated with the two clusters. The use of big data and technology was the reason leading to a successful early containing measures, as described by the JAMA article. So Taiwan not only has the ability to contain local epidemic at very early stage, but also helping other nations in various ways. On June the 7th, after 8 weeks of zero community cases, the Central Command eased restrictions on social activities. A new COVID-19 ways of life was promoted that involved social distancing and wearing masks. Together with economic promotion packages, consumer promotion voucher, several domestic tourism promotion packages. And this weekend, we are launching the domestic island hopping cruise tour. We will make Taiwan the first country in the world to allow cruise ship services to resume after the pandemic. In summary, from the community perspective, Taiwan's effective COVID-19 containment could be attributed to 4 elements: fast and effective response, transparency and trust in public policy making, frequent and effective communications, and use of big data and technology. And that ends my talk. Thank you very much.
Okay, thank you very much, Professor Ma. You clearly succeed the control of COVID-19 in Taiwan. There are many systems we have to learn. Electronic defense system and yes, and you did not lock down, right?
There was never a lockdown.
No, great.
The school was closed all the time.
I see.
Oh, it was open. Sorry.
Mhm.
Yeah.
Can I ask some questions, Prof? Is it too
Please.
late in the day? So I'd like to congratulate Matthew's lecture. I thought it was very, very impressive. I mean, among all the Asian countries, I will give you full marks. And I would suggest you left out one point, which was that Taiwan had a lot of preparation even before COVID-19 came. I think that's also key. As one point that I think post-SARS, you didn't sweep it under the carpet and think pandemic will never come back or SARS will never come back. So there was a lot of preparedness even before it happened. I think maybe just sharing 2 experiences on Singapore. One is that in September last year, Singapore built a new hospital, 300 beds, and it was empty. It's a National Disease and Infection Control Crisis Hospital. And my colleague was condemning it, saying it's such a waste of money, it's empty. And then by February, it was fully housed, and it allowed me to treat cardiac patients because we were not overwhelmed. That's one. And the other one was that Singapore was not advocating masks early on because we were listening to WHO who say that there were no signs of asymptomatic spreaders. So when it happened, I think Singapore jumped on it and enforced by law masking of everyone. I think the mask experience, which is what East Asia is more used to in Hong Kong, Korea, Japan, and Taiwan, is probably actually a better strategy than, and we had to react very fast to say you need masks from you saying you don't need masks, but we had to react extremely fast. So can I ask you, when do you find out that they were clearly asymptomatic spreaders as a point of epidemiology?
I think it's probably in the April. Yeah, but there the community cases are very few in Taiwan. Most of the cases we can trace their target, and maybe 20% of the cases are from people who are rather asymptomatic, using retrospective contact tracing that will identify their carriers.
So that's one thing that in Singapore we had. You are quite close to China, but maybe one statistics, most tourists from Wuhan likes to come to Singapore, Malaysia. So we had a huge cohort of Wuhan tourists in Singapore actually in December, January. Yeah.
We did too. We see quite a number of Wuhan visitors. I think the essence of Taiwan's success is actually we reacted so early. We actually reacted as early as December 31st after we read the internet information from the central CDC.
That is also quite amazing, because how do you react on internet chatter? I mean, I think Singapore took 2 months because we really did not want to close down, being such an open country to Chinese tourists even until February. So I wonder, how do you pick up on internet chatter and say, I don't want someone from Italy or UK to come to me because there's some series of atypical pneumonia that I pick up. How do you do that in the healthcare system?
Well, actually, the guy who is reading the chat room was the deputy director of our CDC. And he saw information released by the hospital, Wuhan hospital, containing the CT scanning, containing the PCR stuff, so he sensed that this is something very, very unusual. And based on our SARS experience, he actually, together with other colleagues and from the CDC, they decided not closing all the flights, but they actually started on-flight quarantine services. They check all the passengers before they enter the customs.
So I would say congratulations, he's got balls, man, because it's not easy to close to quarantine. Yep.
Yes.
Okay, thank you, Professor Ma, and I really appreciate all the speakers and all the audience for participating in this important session. Before closing this session, I would like ask Dr. Jack Tan to have a closing remarks.
Okay. So I don't have much more remarks. I think everyone said it. I just like to say one remark. Maybe we should, every country is different, but we shouldn't let a crisis go to waste, the popular phrase. I think I've seen how every country are using this to their advantage, I would say, and just turn it around. I think Italy has provided a lot of good data coming out from their harrowing experience. And so has UK, I would say, even though initially there was this blowout of cases. But I think you can see that in countries like Korea and Taiwan, what we are looking for is really leadership and transparent, honest leadership to bring us through. And as professional societies, I really like what ESC did to reassure and really send out and help the system and not have the collateral damage hit us. I think as professional societies, we need to do more of that to counter both fake news and to advocate correctly. So with that, I'd like to thank everyone for participating on the Saturday, and thank you, Prof. Akasaka, for a very successful APSC JCS Week 2020. So everyone, please keep safe. We're not quite over yet. We hope the Oxford vaccine works, and keep safe, everyone. Love to see you soon.
Okay, thank you very much, everyone.
Bye-bye.
I'd like to close this session. Thank you.
Thank you.